The other thing you were talking about with gas exchange is I wanted to just have you reinforce the remind. I mean, anybody just with upper airway versus lower airway anatomy is it doesn't all exchange gas.
Sure. Yeah. So you can have anatomical
space.
dead space. Yeah. So you have to take that into account. There is a formula out there. You say about 1 cc of tidal volume for every pound of body weight that they have is considered dead space. So, whether or not that's 100% accurate is given. But you do have to make sure that your tidal volumes are adequate, because if you're underventilating somebody, even though you might think you're doing a great job because of their body habitus or whatever, they may have dead space in there that you don't know about. So, and alveolar ventilation is more important than just getting air into the ET tube, and that's where that inspiratory time comes into play.
Yeah.
Your tidal volumes have to be adequate, but at the same time, you have to let the air go in there, do what it needs to do,
all the way
and
in,
then come back out.
Yeah.
So, alveolar ventilation is important. And how do we accomplish that? Making sure we have good tidal volumes and a proper inspiratory time.
Yeah, and the other thing that I personally have tried to keep my mind wrapped around is we inevitably seem to be putting more and more stuff on an intubated patient or whatnot. There's 100 gadgets and gizmos that wind up between the from the end of the tube to where my circuit, where my the inspiratory expiratory leg of my circuit, depending on which device I'm using. But when we add stuff, we're adding to dead space.
Yeah, we increase dead space. And the newer ventilators kind of make up for that in a sense,
right.
which is pretty
It's really
nice.
nice.
You have a closed loop system.
Yep.
So as long as you're doing your circuit calibration, which you need to do your circuit calibration, a lot of that is going to be made up for. But once you start adding things in between the ET tube and the Y, or which is essentially a Y-shaped piece that connects the tubing. Once you start putting pieces in between there, that's when we run into some issues with dead space. Yeah. In hospital, we use that to our advantage. On some patients, we have neurologic injury patients that they may breathe over the ventilator and push themselves into an alkalotic state, and no matter what we do, we can't change that.
Yeah.
But we'll add dead space into there to make it so that they don't
rebreathing
ventilate as well.
Yeah.
Essentially, they're not ventilating as well. But largely, empirically speaking, if you're going to put things in between the ET tube and the Y of the circuit, you need to take into account that does create dead space. There's a kind of a unwritten rule in respiratory care that every 6 inches of corrugated tubing is about 50 milliliters of dead space. So if you're putting dead space or anything in between the Y and the ET tube, kind of keep that in mind. Like, is this close to the same size as a 6-inch piece of tubing?
And we're sitting here, and both of our statements bring up a point in my head that I think the audience needs to hear is, we're sitting here speaking, having used some of these devices, right, about the Y versus, there's a return on some of it. Talk a little bit about circuit design. Again, we kind of with the focus of pre-hospital, because I started this with, there's some we know of some departments that are getting into this, that have purchased these advanced ventilators, and those have a Y and an expiratory arm. Mm-hmm. And then you very subtly made the point about, hey, some of these newer ones actually have a return, and they're monitoring that. What's the advantage there? And again, to an RT with a an ICU level vent, that's fairly intuitive, but we may have kind of either of those devices. And let's kind of face it, we're kind of talking about like an LTV or an LTV-esque historically kind of circuit, which is a particular brand, and I would say one of the most ubiquitous,
right?
Certainly out of hospital home care, even in many cases relative within hospital, vent, certainly nursing home. And then, the other thing we're kind of nudging up against are some more relatively recent products that we're using in the out-of-hospital space, mostly in critical care transport now, but we're making these references, and we're kind of talking about like the Hamilton T1 and other vents in that kind of same class.
Right.
But kind of talk about
so
that means something, yeah.
Two different ways of ventilating or delivering ventilation. The old school way of doing it, the single limb way, it's considered to be an open loop system. one limb that comes from the ventilator goes to the patient, and then there's some sort of small expiratory valve kind of closer to the patient that allows the patient to exhale. Open loop system is, we think of that even in cars. Open loop system, you send information to the patient, or you send something to the patient, and you get no feedback on what's coming back to you. Okay, and that's how those older ventilators worked. We still have a few of them that we use in case of an emergency, the older care ventilators, but they're very crude. There's usually not a whole lot of monitoring of anything aside from a peak pressure, and that's really about it. So the benefit of using the closed loop system or the dual limb circuit like that is that you have the ability to see return tidal volumes. You can monitor pressures, you can monitor flows, you can see all of those things as if they were on an ICU ventilator. So it's nice to see the industry move away from open loop systems and get into the closed loop systems. But that creates a whole lot more of responsibilities for us on education and just general responsibility for the patient.
100%. That also, certainly in my eyes, gives us the ability to harness some technologies that, because now we know what's coming back, and I'm not sitting here advocating for, I'm simply saying that they exist, some more autonomous vent settings that you give it the general parameters you want, and it's kind of tuning itself breath by breath, using a lot of those things that we talked about earlier with, some of those eye time settings and various things. It's actually making some of those adjunctively on the fly.
Yeah, and I have some experience with those autonomous modes, and our transport ventilators that we use inside of our hospital, they do that. And I'm not opposed to that, and I'm not advocating for or against. Just so we're clear.
Time and a place for everything.
There is a time and a place. And, I've had good experiences and I've had bad experiences with it. But what it ultimately comes down to is that the clinician still needs to know what's going on with their patient. They have to. And,
well said.
I've had some negative experiences that have been based on the fact that the clinician did not know what was going on with their patient. And as somebody who sits there and tinkers with vent settings and makes sure that the patient is the most comfortable and that I understand what's going on with my patient, it can be a little frustrating to have, that technology out there, people using it, but not really even having a clue on what's going on with their patient. Right.
It's much like the AI that wrote these notes here that we're talking about, right? Is I'm choosing to, yes, I used it to give us some ideas to talk about, but it's how I translate this that is the impactful part. And I think you're saying this, exactly the same thing. As a clinician has to still understand what is going on here.
And think back to when we started to first use the Lucas in the field.
Yeah, good point.
I remember the first time I got to use the Lucas in the field for a full arrest, and it was me and another medic. And I'm like, wait, I don't have to do anything. All I have to do is sit here, bag, and push meds. That's awesome. But if you don't understand how the Lucas is working, if you don't understand if it's positioned properly, you're not paying attention to that, it's a complete waste of time, and you can end up hurting the patient.
Yeah,
and that's the same deal with these autonomous modes that we have.
That's a brilliant analogy, right? Because if that thing's positioned over the aorta and you're blocking the outflow, you are not helping.
If it's down here pressing on the diaphragm.
Exactly. Yeah, also not helping, right? That's a great analogy. I like that. I think that's gonna.
I think this is a great idea because I take for granted when I talk about it, like, if I'm doing a resuscitation, I'm at the groin with hand on feeling every pulse, whether it's manual compressions, Lucas compressions, and then if I'm pausing it, I'm palpating for pulse, and then I don't feel a pulse, turn it back on. But that's my feedback, right?
Yeah.
I know what's going on with that patient. If I don't, I can then, if we're doing manual CPRs, I can say, hey, make sure you come up all the way off the chest, so you're allowing the recoil, or you need to go faster, you need to go slower, those types of things.
That is, is it functioning properly? But I'm afraid what a lot of pre-hospital, I don't know how we're going to get off of Lucas talk here, but what a lot of pre-hospital providers is, I set it up, it is where it's at, it must be the best, and then what we're kind of talking about here is, on event, you're constantly changing, reassessing. Okay, that's not working. change something, right? We got to go figure out what and change something. And I see on the Lucas side of things, often nobody thinks about repositioning or moving it. Is it too far? All right, yeah, it's down here, punching them in the stomach. Yeah, okay. Right. But, even subtle little changes. There's a whole body out there of, doing ultrasound guided Lucas resuscitation and do an echo during an arrest to make sure you're optimizing blood flow. And I'm afraid more often than not, it gets thrown on, and if it migrates, it migrates, and we don't hey, that pulse wasn't as strong as it was before. Assuming like you said, that's my metric, right? Why is that, right? Did our machine change? And the things, bringing it back to ventilators is, again, great analogy because that ties in nicely.
Well, a ventilator is a lot more complicated than a Lucas.
Oh, very much so.
And I think that one thing that we talk about technology, it's old technology that we all have, that there is one piece of dead space you should add to all of your patients, and that's going to be a end-tidal CO2, right? So you're going to place your tube, or if it's on a trach, put that in, put that there, so you can then track your end-tidal, because that's going to give you feedback and make sure you've got pulse ox on them, right? So make sure you have good values for both of those. You're going to be surprised, make sure it's calibrated first, because we talked about that. Make sure your end-tidal CO2 is gone through its calibration, and then you put it on, because you might be surprised, and you told the story earlier, that's end-tidal CO2 is 90 or 100. We got to bag that down. And then you get to 40, and now you might, and you should anyways, you're taking a patient from their home ventilator and putting them on a new ventilator, or you intubated the patient, or you're doing any type of thing. I think once you put them on and you set after you get done setting all your values, your next thing is you're going to reassess, and there's probably something you're going to change from that. Oh, hey, my end-tidal CO2 has come down really nicely. I can change my rate that I'm ventilating, or I can change my volume that I'm doing, or hey, pulse ox has been 100%. I can adjust my FiO2. I think that's a very dynamic time when a patient first goes on to a vent or gets changed from one vent to another, that you're going to be fiddling around with those knobs for a little while until they really get tucked in. You're like, okay, they are stable on these settings. But then your reassessment is going to be 15, 20, 30 minutes, and then we're going to get another blood gas in that time frame, or at an hour time frame to reassess. And we might be fancy in the emergency department or the hospital where we're getting arterial blood gases, but I can get enough information from my SpO2 and my CO2 to make those real-time changes to provide the best care for the patient. I don't necessarily need a blood gas to make those changes.
We have all said at some point during this discussion something similar, and I think it just needs to be categorically said, is we match ventilators to the patient. We don't try to make the patient with gallons of drugs and sedatives and paralytics match the vent, right?
Ideally, yes.
There's a time and a place where it has to, but more often than not, we're talking about this fine tuning and making them comfortable and getting them where they need to be.
But short of rocuronium drips, if your patient's desynchronous to the vent, you can't fix that. You need to make changes to that vent to get them to synchronize with the vent. Something's not matching up. We need to fix that.
Yeah,
correct.
We have the ability
I can fix that
let's
with rock, but that's not the right answer.
That's absolutely right.
But no, that's I know you've seen it. I've certainly seen it over the years. Is people just throwing more sedatives at the problem, throwing more analgesics at the problem. And in the critical care space, that is important. I'm not discounting it. But specifically patients that are chronically on vents.
Sure. Yeah.
That's
and
a whole
like you said,
story.
there's a time and place for that. Absolutely. But to your point about fine tuning to every patient, whether it's a nursing home patient or it's a patient that you intubated on scene because they're in respiratory distress and you determine they're in failure, you do have to take that minute to fine tune. Whether even if you're just picking that patient up from a nursing facility or from their home on a home ventilator, you have to let them get settled in. You have to let them get comfortable, because your machine is probably not going to be the exact same thing that they were on, even if you match the settings.
I kind of do that for that reason. I kind of do it a little backwards than many of my colleagues. Many of my colleagues, the last thing they do before they walk out the door is put them on the vent. I prefer to put them on my stuff far earlier. with the one and the point you already made, John, is I'm going to get a capnography on their native vent as a benchmark.
Mm-hmm.
This is where I'm at. I might change that after the fact, but this is where I'm at now. I need to get them onto my machine with at least this set of parameters. I'm using that as another data point, right? And I personally like to do that, assuming we're not just on huge FiO2s and consuming a lot of air, and I can do that if I'm taking a patient, in a transport kind of setting. Is I like to put them on my vent earlier than later, so they have that time to kind of get tucked in, as with your words, and I can make a few changes as we're.
But if
moving them
if
across
they're
them.
on that vent, and not that 31 is different than 32 or 33. 30 is different than 40, which is different than 50, is different than 60. So if they're on them, they're on
Extremes.
Yeah, if they're on 40, 45, great. I put them on mine. A few minutes later, they're at 60. Something's not matching, right? I need to make an adjustment to get that back down to what they were at in the 40s, right?
Yeah.
We're not trying to match point for point, but the general realm.
But in this space,
Yeah.
and I'm certainly like I said, we're concerned about the extremes, right?
Absolutely.
If there's big trend shifts one way or the other, I done messed something up, right?
Yeah.
I need to go back.
And that's why I do reinforce with all of our paramedics that come through, or even our residents that come through to attend ventilator training. Just like medic school, get your view from the door, right? Yeah. Take a look at how the vital signs are on the monitor if you have that opportunity before you even touch the patient. Look at how their breathing pattern is. Are they comfortable? Are they not comfortable? Are they awake and conscious? What does the entire picture look like? What drips are they on if you're picking them up from a facility? But you need to kind of get a good picture of what they're like prior to making any changes whatsoever, so that if you did make your change and they don't look the same, well, maybe it had something to do with the fact that you made your change.
Or you pick up their hypercarbic, you put them on their appropriate settings, and all of a sudden they perk up on you.
Yeah.
You fix the problem.
Airway pressures and the scary alarms that come with them, right?
All right.
Yeah. So let's talk a little bit about, kind of static and dynamic compliance, and, of course, within that is our peak and our plateau pressures, and what relevance does that have, and then probably one of the more common alarms, right? So, what does it mean when we have alarms in those spaces?
Sure. Yeah. So it can be a very, very juicy topic, talking about ventilator values. But there are some basic ones that you need to know. Obviously, peak pressure is important. So that's the maximum amount of pressure that the patient's lungs are going to experience, or the airway is going to experience while the breath is being delivered. So that's the peak pressure. When we talk about something called plateau pressure, that's when the air has gotten into the actual alveolar space. It's had a chance to open up every little alveoli that it's going to open up during that breath. It's overcome the resistance of the breathing circuit. It's overcome the resistance of the patient chomping on the tube, or perhaps their airways that are closed down from bronchospasm. When that pressure gets into the lungs and has a chance to equal out, that's your plateau pressure. And as a respiratory therapist and physicians, we look at our plateau pressure and care a lot more about our plateau pressures than we care about our peak pressures, honestly, because that's what the actual lung tissue is going to see. Peak pressures are still important because it can clue us into some problems, but plateau pressures are, the number one pressure we care about. So causes of high peak airway pressure, if you're running a ventilator outside of the hospital, you're probably at some point going to see a peak pressure alarm.
Yep.
But there's a bunch of different causes for that. You kind of have to go through your process of diagnosing or figuring out what that is. So you could have a breathing circuit or breathing tube that is kinked off. Okay, something as simple as, hey, we move the patient over to the bed, close the rail, or they're sitting, we move them on top of their breathing circuit, and now my ventilator alarm is saying peak pressures, and my pressure beforehand was 20 and now it's 60. What's going on here? We could have dislodged an ET tube when we pulled them over, which usually we see a leak alarm for that process, or a low minute ventilation alarm. But it still can be dislodged, and stuck into something else where it doesn't belong, right? So that's another problem. The patient chomping down on the ET tube is very common. Coughing, another very common cause of high peak airway pressures. Secretions is another thing. So when we start getting peak pressure alarms, we take a look at the patient and see if there's anything you can immediately fix. So if they are chomping down on their ET tube, hey, don't do that. Or, maybe perhaps they need some sedation. We see it very commonly in the hospital where someone, whether it was nursing, physician, we don't know, suctions the ET tube with the inline suction catheter, and they leave it in there.
Doesn't pull it all the way out.
And they don't take it all the way out. This was a very, very common thing in our neuro ICU when I was a brand new respiratory therapist, because the neurophysicians and the nurses are doing their mental status checks and their cough and gag reflex checks. So they would fish the suction catheter down in there, and the patient would either cough or not cough, and they would say, cool, got my answer, and book out of the room.
And walk away.
But they'd forget the suction catheter was down there. So we would see high pressure alarms, and all we would have to do is go in there and gently remove the suction catheter from their airway, and everything was fixed. So, but thinking of that example, anything that occludes the ET tube or the airways is going to cause potential peak pressure problems. So kinked tube, kinked circuit, suction catheter down the tube, bronchoconstriction is another big one. High peak airway pressures tells me that there's high resistance to flow, generally speaking. So anything that can cause a problem with flow going into the patient is going to be issues with peak pressures.
And in the trach patient population, mucus plugs.
Yeah. Depending on the facility.
Still garbage in the airway.
Yeah, they can get some dried out secretions. But we can also see peak pressure problems when we've hyperinflated somebody. So we've gotten to the point where we put so much air in there that they can't exhale at all. So then we run into an issue with, we're trying to bag electronically, and guess what? You can't get any more air down into the ET tube, or into the lungs. So that's an issue. Plateau pressures, though, we pay, like I said, a little bit more attention to the plateau pressures because that's what the lungs are actually seeing. The kind of rule of thumb is that we don't want to see our plateau pressures generally higher than 30 because the alveolar shearing pressures are somewhere 35 to 40 centimeters of water. And that's just a fancy way of saying alveolar shearing pressure means popping lungs. So anytime we start seeing our plateau pressures start gradually increasing, then we start thinking, hey, we got to back down on our volumes a little bit, or potentially our PEEP, because that plays into how much pressure is in the chest to kind of compensate for that. So that's your plateau pressures. Problems associated with that a lot of times are hyperinflation. Okay. Asthmatic and COPD patients, they're going to have a lot of times a high peak pressure, because think of what their disease process is. They've got constricted airways one way or the other. So we're trying to blow air in, or they may be hyperinflated. So we're trying to blow air in and it can't get to where it needs to go. But they have higher peak pressures, but then their plateau pressures are usually lower.
Yeah.
Okay. But then we start to worry when those plateau pressures creep up closer to their peaks, because that tells us, okay, now we're most certainly hyperinflated,
really
and we need to let them exhale more.
Yeah.
So that's two of your pressures. When it comes to compliance and resistance, those can be a little bit more tricky, but they do clue us into some different disease processes. Airway resistance is exactly what it sounds like. It's what's the resistance in the airway, right? But we put a numerical value on that. Usually 5 to 10 is about normal of airway resistance. But the higher the airway resistance, the more figuring out we've got to do what's causing that airway resistance. So maybe give them a bronchodilator or pull the suction catheter out of their ET tube, and you'll see that airway resistance decrease. And then compliance. Compliance can be a little tricky because there is static versus dynamic. In order to get a very good, true compliance on someone, they have to be paralyzed. If you have any patient input whatsoever, they're going to throw all that off, compliance measurements, generally speaking. But we can still get a kind of a good idea of what their compliance is, even without them being paralyzed. And that plays into how stretchable are the lungs. So I like to tell our resident staff when we're doing our ventilator education, having them hooked up to our ICU ventilators, or even some of these newer transport ventilators where you can get those values, it's almost like them being on a little pulmonary function machine. We can see what their lungs are doing. I can tell you by looking at these values, this is almost entirely a restrictive
Some graphical
process.
representation of it too.
And when someone orders DuoNeb Q4 on a patient and they try and do it through the whole ICU, I can go on the ventilator and I can say, look, his airway resistance is 5.
Nil, yeah.
And I gave him a treatment and absolutely nothing changed. And our peak pressures are this. You know, you can argue your way in and out of breathing treatments that way.
Yeah.
But that's a great, fantastic way in the field to be able to tell, hey, is this something that my intervention worked or that I need to intervene with in the first place?
Right. No, that's fantastic. Just a couple of tuning points. Again, it's taken from our perspective, having seen these things, but I imagine there's a viewer out there that's thinking about that. Like, how did somebody leave a suction catheter in somebody's trach or in somebody's airway?
The same way you leave a tourniquet on an arm.
Exactly.
Well,
right. Yeah.
But
things happen.
But there, he's specifically talking about an inline suction, which is not ubiquitous in the pre-hospital setting,
Sure.
right?
Fair.
We've got just a little coiled, whistle tip on the, and you're like, well, how did you put that in and then not take it out?
Right.
But you've got something that actually is in an elbow that is all captive, right?
Sure.
So all,
and it's not to
all
say
of
you wouldn't see that at a nursing facility too.
100%. Yeah, great point. But
I'll just say that vent alarms are the things that keep all of us up at night.
I would agree with you. Yeah.
We've made jokes of we want to really drive someone crazy in medicine, just have something on repeat that's a vent alarm, and it will drive us absolutely insane.
Yeah.
But I love it. My butt puckers when I hear the alarm and I go evaluate the patient, and I love it when it's something simple like a kink tube.
Sure.
That type of deal, because if not, something's wrong, and I got to fix it, and I got to fix it quickly. And I typically, if it's like high peak pressures, like first thing is going to be suction. Can I suction my way out of this? Oh, it's a mucus plug. Great.
Yeah.
But when we're getting down into it, I'm calling you guys to be like, hey, they're alarming. I don't know what's going on. We need to fix this. We fix this now. And you guys are very quickly at bedside to help us troubleshoot this.
Yeah. And pre-hospital, I think that's where the education component comes into. And, if you have the opportunity when you're at your base or you're at your station or wherever you might be in kind of in downtime, and you can pick up that ventilator and play with it and simulate things, put a test lung on it. Or if you don't have a test lung, tape a rubber glove or a latex glove over the end of it, or whatever we're using nowadays.
Nitrile.
Yeah. Put a glove over the end of it and just simulate things. Try and put huge volumes into a glove and see what happens.
See what you get.
You're going to see your peak pressure alarms go off.
Kink the tubing.
Kink the tubing.
All do the thing.
I can't stress it enough that if you have a piece of equipment that you're not familiar with, play with it. Yeah. And that's really the only way that you're going to get better at it.
The way I, kind of keep in my mind, when I close my eyes, when I'm thinking about peak versus plateau pressures, is I hate to oversimplify it, but sometimes, like we started off this discussion, sometimes you have to start with the very simplistic, thought process is, a small pipe with a balloon on the end, right? My peak pressure is the resistance in the pipe. My plat is the resistance in there, plus understanding that when I put air into that balloon, it takes time to stretch, right? And that's that cumulative stretch of everything. So that's kind of my plateau pressure, and that's 2:00 in the morning when I'm tired and things honking at me and I'm silence.
No, that's a great way to put it.
Get my brain resettled. All right, where's my problem? Is it basically middle up or middle down, right?
Yeah,
or upper versus lower-ish airway.
I'll go a little more simpler. Maybe just disconnect the ventilator and try to bag them and see what that does.
Right.
And honestly, if you're worrying about air trapping, that's your fix anyways, is take them off, decompress them, and then put them back on. So it's sometimes worthwhile to be like, I don't know what's going on. I'm trying to troubleshoot it. Let's take them off the vent. Take that out. Vents can malfunction. They do malfunction. What do I feel when I'm taking the machine out? What do I feel when I'm bagging them? It's really hard to squeeze in them. Versus, I got great compliance. I'm bagging them up. Numbers are improving. Maybe the ventilator malfunctioned.
Absolutely. Yeah.
Or maybe the tubing, just something failed.
I've had bad circuits. I mean, I've absolutely grabbed bad circuits. Like, why is this not behaving? This, we'll just take some very basic settings. I'm like, I've done this, 100 other times. Why today? And I guess I've learned to have a lower threshold, especially stuff that bangs around in an ambulance,
Yeah.
rather than sitting in a nice stock room in a hospital, or on a shelf in your ER,
Yeah.
right? Experience all that vibration, and some of these, like little gaskets and stuff, have to be perfectly aligned, or things aren't going to work right. And, connections, although can appear tight, a lot of it's friction fit, just friction fit stuff,
Yep.
right? And there might be, like some unappreciable loss or something in there. So, I've learned on the pre-hospital side of things, or on the transport side of things, to have a kind of a lower threshold for, all right, I spent a minute or two. I've changed all the variables. I can change something else is wrong here.
Sure,
Let's
yeah.
try another circuit as a rule in, rule out, right? If the behavior is the same, all right, it's probably patient vent side things. If it's okay, you just take that out. Just checking things off the troubleshooting list, right?
Yeah, troubleshooting is the key there, and but you can't troubleshoot if you don't understand your equipment.
Yeah.
Or you don't understand the physiology of what you're doing with that equipment. So.
A little earlier, no, we should have talked about this earlier. I meant to ask you about it. You said something about ARDSnet. Brief explanation. That's probably not something a lot of our pre-hospital viewership would spend or have a lot of time. Our protocol, there's protocol that is based off of it.
Yeah.
We told you to do it, but
I would hope that if you have a ventilator and you're working in the ventilator space, and especially because we're coming out of the COVID times,
Also-
ARDSnet was huge in COVID.
Of course.
Right,
Like
yeah.
we're talking about these really respiratory lung sick patients where we're really trying to minimize the trauma that we're causing to these patients when we're on a ventilator. And that's really, I think, being in 2025 and COVID was 5 to 3 years ago, depending upon where you were at in the country.
Yep.
I mean, it's very fresh in my mind. And if I've got a really respiratory sick patient, I'm whipping out those charts because this isn't going well and I need to protect the lungs.
Yep. And I'm not sure that everybody kind of knows that data gets aggregated somewhere, and then some best practices.
Yeah. So essentially, what
Issued.
ARDSnet was a compilation of a lot of studies, and just one big study essentially that looked at the relation of tidal volume size to the mortality rates of patients that were experiencing ARDS, or acute respiratory distress syndrome. So what they found was that the lower the tidal volumes, essentially the better the outcomes were. So that's been kind of adopted into all of ventilator settings.
Yeah.
But there are times when it's not necessarily appropriate. Do our post-surgical patients in our ICU that maybe went in for a CABG or an abdominal surgery, do they need to be on ARDSnet protocol? No, they more than likely don't. Would they be better served by having lower tidal volumes than these ginormous tidal volumes that we used to use? 810
ml,
kilo per kilo. It's better than that, absolutely. So we still stick with that, the lower tidal volume lung protective strategy for all of our ventilators. But does it mean that we absolutely have to follow ARDSnet protocol with every patient? No.
No, you titrate it in. The charts you're referring to, right, is volume and PEEP.
Yep.
Yeah, it's volume and PEEP, and they've got all of that kind of, at least the beginnings of it, kind of figured out for you of where to start with these things with the lower volumes, and usually
and actually,
more
and
PEEP.
FiO2 is involved in there too.
Oh, thank you.
So we have a table, 2 tables actually on that chart, at least the one that we use in our ICUs. That the top table would be low FiO2, higher PEEP, and then inversely the other table would be lower PEEP and higher FiO2, depending on the patient situation.
Yeah.
So, and then
Right.
those are charts that if we have somebody where we're following to the T the ARDSnet protocol, that's printed out and it's taped right to the front of the ventilator, so that no matter who comes in, they know that they were supposed to be on 14 of PEEP and 70%. If I'm going to titrate down or up, this is what I'm going to.
This is why I started. Yeah.
It's interesting because this is my second career, so I'm newer to medicine. I'm a newer trainee, and that's all I trained on was ARDSnet stuff, right? Mm-hmm. The goal has always been in my brain 6 to 8. So when COVID came around during my training, obviously we talked a lot about ARDSnet and these are how we're going to manage these really sick patients. But I never had to unlearn all the stuff I did before.
Sure.
Now, I also remember back in my day, and not because I was doing it, but AED training when we were talking about stacked defibs on patients. Like, I can still remember that, but luckily I didn't have to unlearn the bad respiratory stuff.
Yeah.
So actually, this is kind of this whole ARDSNet discussion is kind of a nice walk into some basic strategies for ventilating a patient. And then one of the more commonly used terms is a lung protective strategy. And so you already kind of set out that we're really using that 6 to 8, that lower, maybe even lower 6 to 8 milliliters or cc's per kilo, used interchangeably. I've started my career on cc's because it was now I've been forced to, everything's. I'm getting better. I'm getting pretty good at it. So with that lung protective strategy, are there any other things that we're sacrificing as far as CO2, or what are we trying to avoid with doing some of these lower volumes?
We're trying to avoid too high volumes and too high of pressures too. The two of those kind of combined. So when we think about lung protective strategies, that's 6 to 8 milliliters per kilo of ideal body weight. But then we also think about our plateau pressures. So we're constantly monitoring those plateau pressures. We want them ideally less than 20, and less than 30. That's pretty much the nuts and bolts of lung protective strategy.
Yeah, and we're trying not to cause any barotrauma or volume trauma, any stretching trauma to the lungs itself.
Right.
Well, to keep this simple, right? Like when we talk about us breathing right now, negative pressure inside our lungs, right? All of these, anytime you hook up a ventilator, CPAP, BiPAP, whatever it is, it's positive pressure inside the lungs. You're, by definition, causing trauma because that's not how this is designed to work.
Right.
Nor works in a natural space.
Yeah, there's an effect on the respiratory muscles too. Within 18 hours of somebody being on a ventilator, their ventilatory muscles start to atrophy. So we
18
know that
hours.
18
I've
hours.
never heard that.
Yeah, so
that's wow.
A big concern for ICU care.
Of course.
Obviously, when we're taking someone from a nursing home or what have you, they're already on the ventilator.
You're beyond that.
If we decide that we're going to intubate somebody in the field, and we're going to sedate them, and we're going to paralyze them, and we're going to bring them to the hospital, they're going to stay in the ER for however long they might stay, depending on the facility and the
Let's
the
hope
busyness.
it's hours, but it's not.
Yeah, it hasn't been that lately. So, and then they get sent up to the ICU where it takes us a minute to figure out, hey, what's really going on with this patient? Do they need to be intubated? And by that point, maybe 24 or 48 hours has elapsed. And for, a healthy younger individual like us, I use the term a little loosely for me, not young anymore, but
you're amongst friends.
But that may not be a huge deal. But you take a 70 or 80-year-old patient that maybe has a few comorbidities, and that becomes very difficult to get them off the ventilator. And as a paramedic going into respiratory school, one of the biggest challenges that I had was understanding that we don't need to intubate everybody.
Right.
And that was, I can remember having the conversation with my respiratory instructor, and he would have these patient scenarios and say, well, we'll intubate them. No, just put them on non-invasive ventilation, and we can save so much trouble in the long run. But in the pre-hospital sense, sometimes we forget that, hey, this is more than a trip to the ER. This is the decision that I make at pre-hospital can affect and will affect
downstream
what happens downstream. And that may affect whether they ever go home or not. This intubating them in the field and putting them on a ventilator could end up with them trached and in an LTAC because we couldn't wean them off the ventilator. When in reality, maybe we needed to try some non-invasive,
something different,
correct something, and things would have worked out differently.
So absolutely. So we know, you and I probably know this intuitively. At best, if I intubate you in the field, the next opportunity to come off the vents the next morning, right?
Mm-hmm.
So you're going to do your spontaneous breathing trials at 7, 8 o'clock in the morning. You're going to round with the ICU team and be like, they passed spontaneous breathing trials. Can we wean them off the vent? Your next opportunity is the next morning, essentially, right? Short of you intubating a patient for airway protection in the field and them being a drug overdose and then them metabolizing
Yeah.
themselves to
Or
freedom
hypo-
and self-extubating,
Sure.
that's the only time that they're going to come off of a ventilator if they get intubated in the field. It's going to be the next morning. So CPAP and BiPAP have saved millions of people from being stuck on a ventilator. I was one of them. I was a 24-year-old trauma patient that was ventilated for 3 weeks, as my family told it, a day away from being trached because I wouldn't come off the ventilator. I was a healthy 24-year-old kid who had a bad trauma. I had nothing. Well, I had pneumothorax, hemopneumothorax, but that was solved a few days into my stay.
Sure.
And I still wouldn't come off the vent.
Yeah, it's definitely a big challenge. Thankfully, in our medical ICU and at CMC, we have some very forward-thinking pulmonologists, and combined with some good RTs that, if they see a patient that comes up to their unit that can be extubated right away, as long as we've got a good picture on what's going on with that patient, we're taking that tube out as fast as we possibly can. And it's nice to have that sort of backing. But, yeah, we do end up sometimes intubating folks and causing more problems than good.
Well, that goes back to my statement earlier. If coming out of paramedic school, if all you have is a hammer, everything's a nail,
Sure,
right?
yeah.
So.
I think that's worthwhile pointing out as to transportation of to where the patient's going. You're going to UH Cleveland Medical Center, tertiary care center. You've got 24-hour ICU care, 24-hour residents rounding that are going to be pushing that.
Absolutely.
I'm a community center.
Yeah.
I've got I've got an open ICU that everyone gets admitted to. ICU is just on consult. They're only there. The ICU doc's only there, let's say, 7 to 5,
right.
9 to 5, right? The last thing they want to do is extubate someone, even if they come at 4 o'clock at night. I don't want to extubate them. No, we'll just let them stay overnight, and we'll do this in the morning when we have all day to get them off the vent, because the last thing we want to do is take them off the vent, and now we have to reintubate them at night with less resources.
Yeah, absolutely a difference in facility and resources for sure.
Driving back, we tangent a little bit there, but back to the lung protective strategies. We talked about that, 6 to 8 ml per K, but that's assuming that they've got stretchy lungs.
Sure.
What if they have some obstructive etiology, something going on? Again, we'll go back to that COPD here.
Sure.
What kind of things do you wind up changing to optimize the vent for those patients as everybody else?
Sure, yeah. I mean, number one is using smaller tidal volumes. We may go down all the way to 4 milliliters per kilo.
Yeah.
We have to understand what's going to happen in that situation where we're delivering less breath, we're squeezing less on the ambu bag. So we need to think like, all right, well, we may not be as effective as blowing off CO2, but we're definitely more effective than putting a bunch of air in there that we can't get out. Right. So using a lower tidal volume, we may use a lower respiratory rate as well, because that plays into our total cycle time and how much time we have to deliver each breath. If we try and ventilate somebody at 20 breaths a minute, that gives us 3 seconds to accomplish each breath. But if we ventilate them at 10 times a minute, now we have 6 seconds for each breath. And we are delivering them less volume over the course of that minute, but the important part is we're getting that air into the lungs and allowing it to come back out. So you can actually do yourself a big disservice if you have someone with a high CO2 and you put them on a higher respiratory rate, but then they're air trapping. You're going to end up creating more problems with CO2 than you had before you started. So it's not uncommon for us to walk into an ICU room and have someone on a rate of 24, 28. I had one last week that was on a rate of 30 and not very well sedated. And she's trying to do her own thing, and the vent's trying to do its own thing, and guess where her CO2 levels went? Up. So as soon as we were able to turn the rate down and then also sedate her a little bit more, we were able to drive that CO2. The scooping maneuver. It's essentially, that's how my brain works. Very mechanical thinking. I know you said the tube and the balloon. If you simplify a lot of these things down to just some very simple thinking, it makes the ventilator stuff easier to understand. So, but generally speaking, asthma, COPD, lung protective strategies, using some different tidal volumes that might be a little bit lower. You also have to think about your PEEP in that situation too. If you're already air trapping in the first place, do we want to use more PEEP, which is essentially air trapping Not all the time. And there are some studies that say that, well, if we use a certain amount of PEEP, we can stent the airways that were closed down. We could stent them open and allow the patient to exhale. It does work in some cases, but not all the time. And that PEEP is also contributing to how much pressure you have in your chest. So in some of our asthmatic or COPD patients that we ventilate, we may turn that PEEP completely off.
You touched on earlier, he finished on PEEP, so let's tie these together as intrathoracic pressure, and you really were talking about negative versus positive pressure.
Yep.
And kind of expanding on that. When we're breathing with negative pressure, right, that negative pressure in the thorax that's being created by my chest wall going out, my diaphragm going down, not only is it allowing air to come in and for us to exchange gas and ventilate, all the stuff we have been talking about, that negative pressure also has some cardiac implications too, because it's pulling blood back up that up and down, right? That big floppy fire hose, as I like to call it, is the superior and inferior vena cava back to the right side of the heart, right? So there is some blood pressure, some cardiac output implications to taking that away, and then going to to your discussion here about PEEP is then adding additional pressure. So how much time as an RT do you spend trying to balance that against blood pressure, or do you kind of like
a lot?
I know you understand that,
right.
but is that like you're in conjunction with the nurse and you who can take and who can give, right?
Yeah, that's a fine line to walk.
Yeah.
So it depends on where we're working at in the hospital, but we see this a lot in our cardiothoracic ICU because those patients, they've been in the OR, they had cardiac surgery, they may have been on pump or on ECMO for a certain period of time. And then during that period of time when they're on ECMO or they're on the pump, their lungs de-recruit, and then they come back out to us, and we're trying to work to re-recruit their lungs, right? Well, what do we do to re-recruit closed down lungs? We use pressure. Okay, so it is not uncommon for the patient to roll out of the OR, be placed on a ventilator, and then we can't, for some reason, bring their SATs above 90% without using high FiO2s. And this may be on an individual that went into surgery on no oxygen whatsoever. Yeah. There's really no reason why they should require high FiO2s. At that point, they need higher PEEP. Okay, so we would do some techniques to try and re-recruit their lungs, and this was something I kind of took to heart and learned as a brand new respiratory therapist working in our surgical ICU at the time was, hey, if I give them a lot of pressure, watch what happens to their A-line. Bloop, 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 bloop. Right. Yeah. And you can see that in real time. It does take some coordination with the nursing staff. That patient is rolled out. They're trying to get all their lines situated. They're plugging monitors in here and there, and they're doing all sorts of their things, chest tube plugging in. And then here I am that's trying to do recruitment maneuvers, and I'm keeping an eye on their A-line and watching their blood pressure go from 120 systolic to 90 systolic to 85, and then that's when I turn my recruitment mode.
You're right, yeah.
So it's a delicate balance, but you also have to communicate with your nursing staff and let them know prior to doing that, so they
I'm
don't
doing
think,
that. Yeah, I'm doing that. Don't freak
yeah,
out.
There's definitely a relation between cardiac output and PEEP, and that's what we need to understand. And that extends not just to the surgical patient, but think about some of your patients you may come across in the field that maybe they're just hypotensive from whatever process they have going on.
Dehydration,
A trauma patient, for example.
Hypovolemia, dehydration, something very simple. Yeah.
You may put them on a ventilator, and all of a sudden you're introducing positive pressure into their chest, and now their blood pressure is going to tank. So you have to be careful of that. That can also occur during the intubation process.
100%.
So in our hospital, we're in codes every day. Our RTs are in 3 to 5 codes a day. It's just how things work on a big campus. In those codes, a lot of times we're intubating somebody, but why are we intubating them? They're unstable, right? A lot of times it can be airway protection, but if we're inducing intubation into somebody, they're unstable in the first place. And what happens when you give somebody sedatives and paralytics, and they're already unstable?
Additional instability.
They become more unstable, right? Yeah. So then we introduce positive pressure into that unstable state,
As a variable,
and we
minor.
tank things even more.
Yeah.
So we do have to be careful of that. Whether it's somebody who we're inducing intubation or they have some sort of disease process where they already have poor cardiac output in the first place, you're going to make it worse with your ventilator settings, but you have to be just cognizant of that. Is your 5 of PEEP going to cause blood pressure issues? More than likely not. But as you approach higher and higher ventilator pressures and PEEPs, yeah, you can run into that.
Yeah, and I think that makes just a great lead into, if you're going to do any type of ventilatory management of a patient who you've just taken the airway on, first of all, you should have already probably tried to push their blood pressure a little bit before you took the negative pressure away. And then when you translate them to, again, we'll keep it simple, a BVM,
Sure.
and by extrapolation of this discussion, a ventilator, and you're adding that positive pressure, you need to have tools immediately available to help correct that blood pressure, because you'll be able to fix some things with your choices on pressure and volume, but you still need to augment in many cases. So, a fluid bolus ahead of time, a couple big lines in somebody, having push dose pressors, having these things, having a vasopressor drip, whatever flavor, immediately available.
Yeah, I mean, simple things like, if they're critically ill, they should have 2 lines anyways, at minimum,
right.
if not more, right? Having fluids going on those patients if they're hypotensive or about that. And I think it needs to be said, before you take that airway, appropriately resuscitate your patient before you go all the way to taking that airway. You need a lot done with a BVM. And we talked about it during our airway series too, is we've got these PEEP valves that even go on to big bag valve masks. Mm-hmm. As long as I'm getting a seal, I can get 5, 7.5, 10 of PEEP. And that can actually help out and actually help with pre-oxygenation and recruiting before I go to do my intubation. Make sure they're actually appropriately resuscitated before giving them especially sedatives and paralytics. And now you're taking away all that internal androgenic access on them that you're sedating and taking away. They're going to crump after that.
Yeah, absolutely.
Going back to knowing when and who to intubate, and I think that I've wanted to say this for the last few minutes, just having to, but if you just put them on CPAP or BiPAP, it takes away all of these problems very, very quickly.
Well,
right?
most of them.
Well,
yeah, I want to get into that when we're just kind of talking about some of the pros and cons of if you want to adopt a ventilator strategy in your department. Ventilation versus oxygenation.
Yeah.
It's the same thing, right?
So it is. Turns out it's not. And honestly, my own education, I was taught those things. Did I really, really comprehend? No. Coming from a time where we hyper-oxygenated somebody, I know that to now be wrong because, we're just squeezing the bag fat. No, oxygen, it was just wrong, right? I think we're in a better place with this now than we ever have been because of capnography. Sure. So we have a measurement of ventilation, and we have an oxygenation measure that we're traditionally accustomed. Actually, I didn't have a pulse ox on my first ambulance, but
tell me how old you are
without saying you're old, right? Same thing, glucometer, right? Both of those things came of age very early in my career, but my point is we mixed up ventilation and oxygenation when I was younger, because I didn't have good visual cues. Now I've got good visual cues. I've got my oxygenation, and that's my pulse ox, and I've got my ventilation, and that's my capnography. It's much easier to comprehend. I think most younger providers are in a better spot than I was when I went to paramedic school, for sure. But nevertheless, if we need to make ventilatory changes, what things do we manipulate on our vent? And then if we need to make oxygenation changes, which things do we manipulate on the vent?
Yeah, so we definitely do need to make the point known that we have to be monitoring both of those things. And oxygenation is one thing.
All the things. We monitor all the things.
That's right, yeah. So we're lucky in pre-hospital now that we can monitor end-tidal CO2.
Yeah.
And that how reliable it is in some really sick patients, it's debatable.
It has flaws,
but
right? So does pulse oximetry.
Absolutely.
Yeah,
and in hospital, we're monitoring more blood gases than we are end-tidal CO2. However, we're still paying attention to, is this an oxygenation problem, or is this a ventilation problem? Is this an O2 problem or a CO2 problem? And actually, when any of us who have done test prep for our respiratory programs, one of the things they tell us to remember, when you're looking at a blood gas, and you can just say this about EMS too, when you're looking at a patient, is this an oxygenation problem or is this a ventilation problem? Or is it a both problem? And we'll talk about that more when we're looking at CPAP versus BiPAP in the near future here. But when it comes to oxygenation, we have like two, maybe, I'd venture to say 3 settings that we can manipulate on the vent to get better oxygenation or to affect oxygenation. Obviously, you have your FiO2. That's the simplest. But that's the drug form of oxygenation. Okay.
Great. I like that
Then
a lot. That's great.
We have the mechanical form of oxygenation, which we could say is PEEP.
PEEP.
Okay. Because it does a few things for us. We've talked about them already.
I love that.
It's going to help move any pulmonary edema that might be in there out of the way. It's going to help open alveolar space, so we have basically more real estate to do gas exchange. And then we have something that we talked about earlier, inspiratory time. Think of it as exposure time.
Saturation.
Okay?
Saturation.
Yeah. So if we think of
that.
inspiratory time linked to our oxygenation, as far as what's going to help us oxygenate more, the longer the inspiratory time, generally the more time we have for alveoli to recruit and for gas exchange to take place. But we have to be very careful about that we don't screw up the I to E ratio or inspiratory to expiratory ratio, so that we're not giving them so long of an inspiratory time that they can't exhale. There are times when we do take advantage of that with our advanced ventilation modes, APRV, it used to be called inverse IE ratio ventilation.
Right.
We used to do that. But so we do take advantage of that. But those are the 3 basic settings for oxygenation, FiO2, PEEP, and inspiratory time.
I absolutely love that analogy with the drug form and the mechanical form. Totally going to steal that.
When you think of oxygenation, I mean, there's 2 ways to fix it, and every disease process is a little bit different. Do I need a mechanical fix to pulmonary hypertension? No. Ultimately, maybe from a medication standpoint we do, but from a ventilator standpoint, we're not going to fix a whole lot with pulmonary hypertension or treat it with a ventilator. We need the drug. But if you have the post-surgical patient or the let's say if we're looking pre-hospital, we're thinking about the post-surgical patient. They got discharged from the hospital a week ago. They had abdominal surgery, and they've had a little pain, so they're not breathing very deep.
Deep is the word.
They've got a lot of atelectasis. That's not somebody I'd necessarily intubate. But if you ended up going the intubation route, FiO2 is not going to fix that problem. Pulmonary positive
mechanical
pressure is
fix,
right. So we think of oxygenation. Is this a drug problem or a mechanical problem? Which one do we need?
Love that. Intuitively, I've known that. That's very polished. I'm totally stealing that. I love that.
Someday I'll make a flow sheet. All that. But then when it comes to CO2 removal and we think of ventilation, we need to think what's going to affect our minute ventilation, which in the hospital, when our attendings or fellows are talking with us as respiratory therapists, we're not necessarily sitting there and saying, hey, their CO2 is high, we need to go up on their tidal volume. No, we say, hey, bed 17 CO2 is high, I'm going to go up on his minute ventilation. Okay, because minute ventilation is comprised of your respiratory rate and your tidal volume. Those 2 things together are what actually ventilates the patient. You could have a great set tidal volume, but if you have a respiratory rate that's too low, your minute ventilation is also going to be low, and you're not going to ventilate the patient appropriately. So for CO2 removal, we think minute ventilation, but we think of what is comprising minute ventilation, respiratory rate, and tidal volume. Okay, and then inspiratory time can play into that as well a little bit, because like we talked in the very beginning, if your inspiratory time is very low or very short, like less than 0.8 of a second, you don't have a whole lot of time for gas exchange, right?
Yeah.
So you're not going to blow off as much CO2. Or if it's inappropriately high, you're going to air trap potentially, and then also not blow off some of that CO2. So inspiratory time kind of does a double feature there, but generally speaking, oxygenation is going to be PEEP and FiO2, a little bit of inspiratory time, and CO2 removal is going to be tidal volume and respiratory rate.
Awesome. Very. Have you gone over that before?
Once or twice.
Yeah,
I
it's
think.
absolutely awesome. Anything else in the ventilator physiology, ventilator setting, mechanics of ventilation, space that needs to be said before we start kind of talking about some of the operational stuff? And
I would have to say that you have to understand how your equipment's working. And, it's one thing to understand what a tidal volume is and respiratory and PEEP, but you need to know what is being done with those settings. You need to know how it's affecting the patient, because at 2 o'clock in the morning when that high pressure alarm goes off, you need to be able to troubleshoot, but then also you need to know, okay, I'm hitting high pressures because my tidal volume is too high. So I'm going to back off on my tidal volume, but then my minute ventilation is also going to drop.
Is going to take a hit.
So what
Yep.
do I have to do? I have to respond by increasing my
Rate.
respiratory
Yeah.
rate. So it's not enough to just know the equipment, but you have to know how it's working, physiologically what it's
relationships.
doing, and the relationship between volumes, pressures, minute ventilation, and CO2. You have to really want to know what's going on with your equipment and your patient.